Module 3, legal issues, infection control, restraints, and a little bit I will talk about nutrition. The legal basis for nursing practice. The Nurse Practice Act provides laws that control the practice of nursing in each state and mandates that under law only licensed professionals can practice nursing. Somebody else can't come into the hospital and say, I'm going to start IVs and I'm going to do assessments and do all the things that nurses do. It's illegal. The legal basis for nursing practice. The standards of practice identify the minimal knowledge and conduct expected from a professional practitioner based on education and experience. Nursing practice is guided by legal restrictions and responsibilities regulated by state nursing practice acts. Practice is also guided by professional obligations. Types of law. There's civil law, which protects the rights of individuals in situations which generally involve harm to an individual or property. There's negligence, is failure to use care that a reasonable person would use under similar circumstances. There's malpractice, which is professional negligence, misconduct, or unreasonable lack of skill resulting in injury or loss. So I think the key there is it's misconduct that results in a loss. Just because somebody doesn't like the outcome of, let's say, a surgery doesn't mean that there was misconduct, it doesn't mean there was a loss, and it doesn't mean there's unreasonable lack of skill. So there has to be very specific things to mean somebody is guilty of malpractice. The Good Samaritan Act, it protects health practitioners against malpractice claims for care provided in emergency situations. There's a car accident, you're a nurse, you stop, you assist. Let's say that you accidentally break somebody's rib, you're doing CPR. They can't sue you because you were performing under the Good Samaritan Act. You had attempted to help, and if you performed in a reasonable and prudent manner within accepted standards of doing CPR, then really you're covered. Legal infraction terms. There's assault and battery. Assault is unjustifiable threat or attempt to touch. Doesn't mean you actually touched them. You could still be guilty of assault. Battery, any intentional touching or injury without consent. The most common legal issues related to nursing practice involve informed consent, which is written agreement from a client to perform a procedure or treatment based on knowledge of facts, risks, and alternatives. Informed consent, there's three parts. The client must have the capacity to understand the procedure. The client must give the consent voluntarily, and enough information must be given to be fully understood. Of course, all of this must be witnessed by an authorized person, such as a physician or nurse. Let's talk about restraints. They are used to limit client mobility. They can be physical or chemical, meaning they can be an actual restraint or they can be a medication that restrains the patient's movement. The primary purpose is to reduce injury for the patient or others, staff. Restraints. Alternates to restraints must be tried prior to the application of restraints, including reorientation, frequent toileting, ambulating and repositioning frequently, trial of relaxation technique, encouraging family to stay with the client, or attempting to determine the cause of the need for restraints. All of these must be tried prior to putting on the restraints. Documentation of restraints. You have to follow your facility's policies, which protect you and them from legal action, but an assessment is required at least every 2 hours. Document the patient's evaluation process. Why was restraint needed? List the behaviors and list all the alternates you tried. Document the requirement for an order or protocol authorizing the restraints. So a physician order must be time limited. It just can't be put patient in restraints for an unlimited period of time. Verbal orders must be signed within a time specific in the facility policy. So if your facility has a 2-hour time limit for a physician to come and sign verbal orders, then they have to come there within 2 hours. A PRN or as needed order is never allowed. You can't say restrain if you want to or if needed. Documentation of restraints. Document on your ongoing assessment and care of the patient all the nutrition, the hydration, elimination, special nursing services, and follow policy regarding frequency of documentation of ongoing assessments. Applying restraints. Take caution that injury does not occur due to restraints, which is unfortunately, it must have been a fairly common thing for the Joint Commission and other agencies to really follow this, track it, and evaluate it. Tie the restraint to the bed frame, not to the bed rail. If you tie it to the bed rail, when you move the rail, you could injure the patient. It'll tighten up the rope and/or hurt that patient. Use a knot that will not tighten when pulled, a clove hitch, and pad bony promises when needed. So keep things like the sacrum, the shoulders, keep something underneath that because they're not able to move as much as they would normally. Types of restraints. There's the mitt restraint, goes over the hand, the belt, which is just a belt that is tied to the bed frame so they can't get out, jacket restraint. There's always, the more common ones are the wrist or ankle restraints. And the thing about restraints is you can't make your own. You can't do a makeshift restraint. You can't tie a bed sheet around them and use it as a jacket. It has to be an approved restraint. Confidentiality. Nurses are legally and ethically obligated to keep information about patients confidential. The tort of invasion of privacy protects the patient's right to be free from intrusion into their private affairs. Patient privacy is regulated by the Healthcare Information Portability and Privacy Act, otherwise known as HIPAA. The American Health Insurance Portability and Accountability Act was passed in 1996 and was required to be instituted in April 2003. It requires that patients' health information be available only to those with the right and the need to have this information. Nurses' role in maintaining confidentiality. Don't discuss information where others might overhear. Protect your computer screen from being viewed by visitors or actually anybody that doesn't have a right to see it. Protect patient's chart from being viewed. Do not share your computer ID or password. And access transmission of patient information via internet requires strict scrutiny. That means it has to be HIPAA compliant in order to you to text or email any kind of patient information. Hospital accreditation agencies. There's 3 regulatory agencies that now exist that do accreditation. That's not just the Joint Commission anymore, although they are the most common and the most frequently cited on all kinds of patient safety issues. There is also the Healthcare Facilities Accreditation Program, HFAP, or the Detnorsky Veritas Healthcare, otherwise known as DNV. The Joint Commission's National Patient Safety Goals, introduced in 2003, they update them annually, and they're written by a group of experts who review all of the sentinel events, unexpected occurrences involving death or serious physical or psychological injury. So the safety things that the Joint Commission comes up with are based on what they find out in all the hospitals that they're reviewing. Experts define problem areas and advise the Joint Commission on how to remedy these problems. National Patient Safety Goals for Hospital. In 2013, there were 6 major goals. There's a lot of subcategories, but we're going to go over the 6 major ones that hospitals must follow. Goal number 1, identify patients correctly. Use at least 2 patient identifiers, including assigned ID number, social security number, name, date of birth, or whatever your facility recommends. Follow the organizational policy. Goal number 2, improve staff communication. Includes guidelines for verbal orders. Hospital must develop a list of abbreviations, symbols, and dose designators that are not to be used, so the do not use abbreviation list. Must develop guidelines regarding abnormal test results and time for reporting. How long does the lab have to call the nurse to let the nurse know that the potassium is 7? So often it's a 30 or a 60-minute rule, depending on your facility. And you must create a standardized, consistent approach to handoff communication. Goal number 3, use medication safely. Standardize and limit the number of drug concentrations. Identify and review look-alike, sound-alike drugs. Create a list of high-risk medications and have them labeled. And patient identification must be on all medication containers. National Patient Safety Goal number 4, prevent infections, proper hand washing, which is always the simplest one, although it's the most difficult to implement in organizations. The good thing is there is a lot of waterless sanitizers, there's sanitizing lotions, there's things that are hung on hospital walls to dispense alcohol-related sanitizers. So it's becoming easier for healthcare providers to wash their hands, and it's a good thing, as it's the number one problem with infection control. Hospitals are also required to review infections leading to death or major permanent loss of function while a patient. So they're supposed to report all infections, and especially the major ones. Goal number 5, use medications safely. Compare current medications with those ordered when admitted. Communicate complete list of meds to the next provider. Number 6, identify patient safety risks. Implement a fall reduction program and implement evaluation of effectiveness of that program. Patient falls. Falls are the leading cause of accidents among older adults because of a decrease of strength, balance, vision, and hearing, which can lead to falls. Most insurance sources will not pay for costs associated with the fall, and some of them will not pay for any days after that fall occurred. Fall risk assessment. Identify clients at risk on admission and throughout hospital stays. Fall risk assessment tools identify the risk level based on ability to ambulate, physical condition, what medications they're on, especially narcotics or sleeping pills, orientation, history of mobility problems, what assistive devices are recommended, and also which ones are being used by that patient. Nursing interventions to prevent falls. A lot of this is common sense. You identify the clients at risk, you implement the fall prevention precautions, and you do little things like place items within easy reach of the client, the call light, the water, whatever they have on their bedside table. You assist them when they get up, or you provide devices to help, and you teach the client and family members about the precautions used in the hospital, like the no-skid footwear, how to use the handrails and why, signs or visual reminders to let everybody know this patient is at risk to fall. Infection prevention. Medical versus surgical asepsis. Asepsis is the absence of pathogenic microorganisms. So there's medical and there's surgical. Medical means maintaining a patient at the environment as free from pathogens as possible. Surgical asepsis is eliminating all microorganisms, non-pathogenic and pathogenic. Let's discuss surgical asepsis principles. Use a sterile field for sterile materials. Keep hands in front of you and above your waist. You often see surgeons with their fingers intercrossed right by their chest, holding it above their waist so that they don't accidentally touch something. Edges of a sterile container are not sterile once opened. You have to assume that they may have been contaminated. A dry field is necessary to maintain sterility of the field. That means if it gets wet, bacteria can soak in through there and it's no longer sterile. Nosocomial infections. An infection acquired while a patient could be caused by the bacteria, virus, fungi, or parasites. Patients that are high risk are multiple illness, elderly, or lowered resistance. Iatrogenic infection. An iatrogenic infection is a type of nosocomial infection resulting from a diagnostic or therapeutic procedure, basically something that happened from the healthcare provider. Example, a urinary tract infection that develops after a catheter insertion. The 6 links in the chain of infection. The infectious agent, such as the bacteria, the reservoir, which is the human host, the portal of exit. Let's say that you have pneumonia. The portal of exit is your cough and the droplets that come out of your mouth. Mode of transmission is the droplets. Portal of entry means it's the other individual who you coughed on. They're breathing that in. And they have to be a susceptible host. Not everybody that gets exposed to a bacteria is going to contract or come down with a disease associated with that. Medical asepsis principles, also known as clean technique, not surgical technique. It includes hand washing, standard precautions, isolation technique, cleaning and disinfecting of equipment, So what you would do for all patients, you come into the room, before you do, you wash your hands. If you have to touch something that you may believe has blood or bodily fluids, you're going to wear gloves. Isolation techniques, if they are on any other kind of isolation, you will take measures to reduce the chances that you're going to catch that. And cleaning and disinfecting of equipment after each patient use. Infection control. Standard precautions is the primary strategy for preventing infection transmission. Hand washing, glove, mask, gown, things that will protect you from carrying that bacteria. Let's talk about communication now, therapeutic communication. Any answer that has non-therapeutic communication is the wrong answer. What types of communication are there? It's more than just the spoken word. It's more than verbal. It's non-verbal cues. It's active listening, meaning repeating what they said back so that they can either confirm or deny that that's what they meant. And there's a lot of variables that influence this communication. Your perception, your values, what culture you're from, if you're male, female, how old you are, what generation are you from, developmental level, and environmental factors. Characteristic of a therapeutic relationship means you've developed a relationship with the patient and you have mutually determined goals where you decide, okay, I think that you need to get up today and you need to walk at least 100 feet. This is going to be your goal. This is where you need to be at. And the patient and the nurse agree, they talk about it. That's a therapeutic relationship, therapeutic communication. This is goal directed toward meeting the patient need. It maximizes the patient's potential for growth using the environment, walking in the hallway. And it's about patient learning new coping skills. Let's say that they had a stroke and they were learning to walk again. So you're assisting them with their new coping skills in walking. Predictable phases of the relationship. Essential conditions for therapeutic communication: rapport, trust, respect, empathy, genuineness. These are all essential. You can't have a relationship where you're expecting some kind of mutually designed goals if the other person doesn't trust or respect you or doesn't believe that you're genuine. Cultural considerations for therapeutic communication. It's important to view the characteristics associated with a specific culture. So if you can, do the research prior to, if somebody is from another culture and you are not familiar with that culture, look at personal space, eye contact, use of touch, silence. Sometimes eye contact can be disrespectful. Sometimes if you don't make eye contact, it's disrespectful. So it all depends on what culture they're from. Now let's go over a little bit of nutrition. So there are 5 food groups, and we're going to just start with the basics: bread, vegetables, fruit, milk, meat. This is the mypyramid.gov food pyramid. And some common therapeutic diets. Discuss foods that are and are not allowed on the following diets: regular, soft, mechanical soft, clear liquid versus full liquid, no added salt, high fiber, American Diabetes Association diets. So these ones we will discuss at the end of this session, and we will have some more details on all of these. These are some things that you probably are pretty familiar with, but it's good to know the details on these prior to the test. Nursing diagnoses for nutrition: body image disturbance, altered nutrition less than body requirements, and altered nutrition more than body requirements, and self-care deficit related to feeding. These are some common ones. Let's talk about tube feedings. Enteral tube feedings involve the delivery of formula via tube to the stomach or the jejunum. So it includes NG tube, which is a nasogastric tube, a gastric tube, which is a G tube, a jejunal tube, which is a J tube, all 2 different areas in the stomach or small intestine. Nursing care with the enteral tube. So you check for placement according to hospital policy, but an X-ray really is the only positive method for placement. Make sure that you assess the bowel sounds, you assess skin around the insertion site, and you keep the head of bed elevated for continuous feedings and during intermittent feedings to prevent aspiration. You put the head down, all those feedings are going in, they could come right back up. Nursing care When delivering medications through NG or G tube, make sure you dissolve the tablet in enough water to make it passable down the small tube. You flush the tube before you give the medication, and you flush the tube after the medication. If that tube gets clogged, you may have to put that tube, take it out, and put it down again. And it's very uncomfortable for your patient. It's best to do the technique the right way so that doesn't happen. And it's often necessary to monitor their blood glucose. If one of these formulas has a high glucose content, it could definitely affect their blood sugars. Total parenteral nutrition, that's TPN. It's a form of nutritional support which nutrients are given intravenously. So there's often a lipid one, which is a white, it looks like fat, which is basically what it is, and an IV, which includes all the rest of the vitamins and protein. So it's given only via central venous access. There's a lot of complications that could occur with TPN, so what you have to do is meticulous care of the venous access device. That means making sure that the skin care or the dressing changes are done per hospital protocol to prevent infections, and make sure that you prevent metabolic, electrolyte, and fluid balance complications by monitoring the lab values and noting any abnormalities. And that's it for this session. Thank you.